NextStep, a clinical recovery intelligence platform that uses smartphones, computer vision, and AI to capture objective recovery data between visits and improve patient outcomes. Previously, Dr. Dublin served as a physician in the U.S. Army, where he rose to Deputy Service Chief at Walter Reed National Military Medical Center, leading the Podiatry Department and serving as a medical consultant and surgeon to the President. He later served as a medical officer at U.S. Food and Drug Administration, FDA, advancing innovation in medical technologies. Thank you very much, Dr. Dublin, for being here, and please take it away.
Thank you. Can you hear me?
Yes.
Okay, perfect. Continue to share. Perfect. So let me get this up. Okay, so thank you for the opportunity. I really am a proponent of what you guys are doing at C2Ship. Sitting in my role at the FDA, it's quite clear that, there is a disconnect between innovation and really the end user or the patient. So I really applaud what all of you are doing here. Um, can you hear me okay?
Yes, Dr. Dublin. Thank
Okay,
you very
perfect.
much.
So this is what we've built. If you could see on the screen, these are some screenshots of what we've developed. As mentioned, we do use the patient's own smartphone to drive patient compliance and education. The goal of what we're trying to achieve, and I think I've actually already heard it here through this group, is we're trying to drive efficiencies within an existing infrastructure, whether that's a hospital system, a clinic, or even a government payer, all the way up to the government users. That's what we're trying to drive. And really, what we found in the thesis of all this is that the wearable, if it's anything outside of the phone, it's just not as good, right? The patients are essentially addicted to the phones, not just patients, all of us. And that's one piece of hardware that the patients tend to always have. So our goal was to tap into multiple modes of input, use our AI algorithms as well as our patented computer vision to structure the data that is obviously unstructured and present it to the provider in a way that's useful, and also induces a behavioral change from the patient. So I'll get into it here. So obviously, as you all know, the diabetic patient has a problem sensing that something is wrong. And this is where the crux of the issues lie. Like right now, we essentially wait for the patients to decide something's wrong enough between visits, whether that's some gas, maybe you have some purulent drainage, even just stalled recovery. If there's stalled recovery, you don't know until you see the patient, some weeks later. And depending upon who the payer is, it could be 12 weeks, right? So we're really depending on that patient to figure out something's wrong. And as we all know, they're neuropathic, so that ability to sense something's wrong is already delayed. This is obviously my patient. Those are my hands, thumbs down, right? Like nobody wants this outcome. We're all working and dedicating our lives to prevent this. So, this gentleman came in to me. He's actually wasn't really obese. He was just, diabetic, didn't take care of himself the way he ate. As a farmer, he depends on his feet. So, it's really gut wrenching, and I guess it goes against our Hippocratic oath or what's inside all of us as surgeons, to really cut somebody's limbs off. And I'll get to the follow on later, but the transmetatarsal amputation is quite expensive. Some estimates are all the way up to 50 to $100,000 per that episode and total amount of care. We all know that the below-knee amputation is horrible. But the costs are really what amount to the draw on the system. So, it can cost all the way up to $500,000 for the total care after or including the below-knee amputation. And then the mortality rate can be up to 80% at 5 years. These are all stats all of you know. So I'm not going to get into, the economics of it, but that's what we're all trying to solve. Now, this is our team. As mentioned, I was at the FDA, but I'm also currently getting my MBA at the University of Virginia. Artem, who is my co-founder, actually the founder, is the CTO and the technical expertise. He manages a team of three out in Warsaw, Poland. And with that team, we are able to prototype, develop both large language models as well as devices or software applications for the patient and or the end user who is the client. Deborah, who's on this call, worked at the NIH for 16 years and served as a director of strategic partnerships, and she really helps us drive all of our clinical partnerships, whether that's with Yale or some of the larger orthopedic groups that we work with, to really validate what we're saying. And I guess the key to all this is that with the data that we have, it's not just clinical outcomes, but it really has to speak to the economic outcomes that we're driving. And getting that MBA really has allowed me to focus on that a little bit more. A group of students and I are actually publishing a series of white papers evaluating AI and technology implemented within healthcare currently. So I'll be happy to share that with the team. So this is really what NextStepCare does and how it works. Specifically for the diabetic population, we use the front-facing camera and our patented computer vision algorithms to really get, I guess what was missing from a picture is the depth. Now, what we're able to get with depth is really the volumetric scan with the accuracy down to 1 millimeter for any wounds. Fortunately, Artem doesn't have a wound. That's actually his foot. But as you can see, we're able to grab the accuracy down to 1 millimeter. But what we do with that data is the more important thing. So we focus on grabbing that input and then focusing on structuring the data to present it to both the patient and the provider to track that progress. So overall, what we're doing is we're having the patients come in earlier. So instead of me performing a TMA, I can hopefully just do a debridement with some antibiotics, or at least if I have to do a TMA, I'm able to do a more distal TMA and plan properly with the vascular team to ensure that there's flow. Now, luckily, this gentleman did heal well. That's his foot. He's back farming. But this is like the best case scenario. And if we have any surgeons in here or anybody that's really in this day to day, you know that this doesn't often happen. I mean, there's wound healing complications. The patients themselves develop compensatory ulcerations either on the other side or the same foot just because of the biomechanical changes. And the thing in my experience that is uh, really determined if the patient is going to heal or not is the family or the support system. And that's what we at NextStepCare are also driving is the ability to, I guess, crowdsource or use the family to see virtually if the patient is recovering, stalled, or getting worse, right? So that it's not just on the patient to determine that. There's also family members involved, right? And it just drives accountability within that patient. So with that early detection, they come in, weeks before they're stalled. There's obviously longitudinal vision between there. And then really what drives it is that we're using AI to signal, is there an escalation or deterioration in recovery? And that now drives a signal to both the provider and the patient to kind of get in touch and close that loop. We're not diagnosing, we're simply marking and bringing those signals to the correct people at the right time. Now, we're going to reduce the readmission rates. Obviously, that's an economic outcome, but really the patient is going to benefit because you're doing the right thing for them the first time, right? We're not trying to piecemeal these patients all the way up to a BKA. We're trying to make that one index amputation the last amputation. So we shorten the time to healing. They can get back to work, get back to their families. Now, as we're able to grab data from across large populations, we can now evolve our LLMs, right, and have objective data to evaluate if what we're doing as a whole, as an industry, is correct. And really, that's what we're trying to drive is the efficiencies within the existing infrastructures. Here's how it works. So the patient obviously puts their foot over the top of it, grabs it, and that the user interface is key because the population that we're dealing with obviously isn't the most tech savvy. It's the mobility issue can also drive compliance or a reduction in compliance. So we calculated how to use this in the easiest way possible. So the patient simply just puts it over the phone, hovers their foot, or just puts it over there, it turns green, and it captures the wound. Then we use AI to track the composition of the wound. We have a human in the loop to confirm the dimensions, which is the real key. But then we are using AI, specifically OpenAI right now, but we're moving to Google Cloud products likely to do the forecasting and analysis of the composition of the wound. That's securely uploaded using our HIPAA compliant pathways, currently stored on a HIPAA compliant node at AWS. And then it's all presented to the provider in a easily digestible way. So it's not just a bunch of data, it's the pertinent data, right? And we can grab steps. I think the walking was mentioned, really anything that ties into Apple or Google Health to include sleep health. We can layer into this. The goal is to have a platform where it is agnostic to diagnosis or specialty, but we are able to overlay various data inputs. And it's up to us to work with the end user, whether that's the specialty clinic or the hospital or the government, to define what the outputs that they care about are so we can drive the end goals of that organization. And obviously, it's up to drive patient outcomes, but I'm fortunate to be in school right now learning from this professor. His name is Ed Freeman, and he kind of came up with the stakeholder theory. And the stakeholder theory just looks at everybody in this chain, right? So if we can help the therapists and the family members and the social workers and even the insurance payers drive patient outcomes, that is probably a better method of doing it versus just simply looking at patient outcomes alone. And that way you have buy-in along the chain. And that's really what we've seen so far in our experience. Let me see if this video works. Is that playing? I think so.
Yes, we can see.
Okay, great. Cool. It's a little video we have there. Nope, nope, nope. That's not it. That's not what I was trying to do. Sorry. All right, great. I click the next. There we go. So these are our verticals where we're really focusing in on as a company. I just want to share that to date, we've raised approximately $750,000 through essentially friends and family and one venture capitalist. So our goal is to essentially establish our presence in these three verticals. And really, these are where we're getting most of the demand. We have very limited outbound marketing or outreach, a lot of the demand has come in both through the Rural Health Initiative, which we are responding to the multiple states right now across all three of these, but also the institutions from Hopkins to Yale, as well as the governments from Ireland all the way out to Western Australia for the stroke and neurorehabilitation. So I would love to hear from any of the institutes or researchers. Please reach out to me if these are in alignment with any of you outside of wound care. I know we're speaking about wound care today, but these are our three areas of focus simply because we can use the computer vision, whether that's skeletal tracking or our wound care capabilities, to kind of drive efficiencies through all three of these verticals. Um, we also have facilitated clinical trials for Johnson & Johnson, Arthrex, and soon to be Stryker. And how we do that is essentially using what we have been so far with the patient's phone. We're able to grab the performance data both retroactively about 3 years, and we can trend the progress utilizing the AI. Now, being able to continuously grab passive data, I don't have to explain any of that to you. You guys probably all know about that. But really, what you do with the data, kind of trying to project forward and displaying it to the provider in a digestible way, that's kind of where we shine. So just some defensibility. Why hasn't it been done before? I mean, it's kind of hard to get through the regulatory part, not impossible. And then we do use our patented computer vision. But really, where we feel the defensibility is the compounding knowledge, layering all of the data that we get from each of these diagnoses, as well as the treatment protocols, to see if they are actually doing what they're intended to do or at the rate that they're intended to do, is going to drive efficiency and savings within existing infrastructures, as mentioned previously. Here's some of our traction and proof. As mentioned, we've been through the FDA, software as a medical device, HIPAA compliant. We've conducted research trials for Johnson & Johnson, multiple manuscripts, now AOFAS, and we will be presenting at the Mayo Research AI Research Summit in June next month. We have thousands of patients and dozens of providers through multiple institutions and large organizations across the United States. And the thing that I'm proud of the most, I guess, is that we've demonstrated 74% compliance/engagement with our patients versus the historically reported 34% with, traditional handouts. And I've really seen that in my own practice, especially with some of these sports medicine patients where, traditionally we just give them a handout or send them to physical therapy. Now, in the Washington, D.C. area, some of our patients are waiting up to 9 weeks to get the first physical therapy visit. So this has been very good as a bridge, but also it's diverted the need for physical therapy in about, about 1/3 of those patients. So that's how we're able to go to the kind of the national health systems, whether that's in Europe or even in India or Singapore, and help them get some of those patients off the wait list. Our goal is to just make sure that the right patient goes to the right provider at the right time, simply put. So we are reimbursable through CMS, and we've demonstrated that over hundreds of patients, we are getting paid by the private payers. And we are currently in the plug and play accelerator, which has allowed us to, as I mentioned, scale globally. So we are speaking with governments in India, Ireland, and Singapore. With that, I thank you for the opportunity to present. My contact info is on the bottom, and I welcome any questions.
Thank you very much for the talk. Sorry, my voice is a little bit sick today, but great talk. And I really like your approach using a cell phone. The fact that you don't need anything else other than the cell phone
Yeah.
to do that. The fact that everybody has a cell phone or will have a cell phone, that adoption of the technology is definitely easier. Just a question on the practical side of it. I just saw that you showed in the video that you need to adjust your feet in the silhouette that is
Mhm.
on the phone. And I'm sure for younger people that's easier. What's your adoption rate on that one on elderly? Maybe if you have wobbling feet, what would happen?
Yeah, so the elderly, because it's on the floor, it's easier than obviously having to have it up. So we're going to grab
Okay.
more patients than you having to hold it in your hand, right? But obviously you're correct. I can't grab everybody. So
Yeah.
that's just one piece of data that's input that I don't get. If I can get them to at least take a picture, right? Because it also grabs a picture in
Yeah.
there. It's just I don't grab a perfect volumetric scan. I still get a picture into the chart.
Okay. Yeah. Thank you. Michael, do you want to ask the question?
You already did kind of.
Yeah.
We tried that type of application with regorafenib, Stivarga patients on chemotherapy because they developed the hand-foot skin reaction. And one of the possible early diagnostics, and this is a medication that you take at home. So the physician is in remote communication with the patient. So to intercept the early onset of the hand-foot skin reaction, we were trying to take the images and share with the physician dashboard to make physicians remotely diagnose the condition. But we did not succeed. The problem was the interference with light. I mean, you are doing the smart thing with the frame for the foot, so it's out of focus. This is something, it was a few years ago. The technology was not necessarily there yet for this type of autofocus. That's helpful. However, still the question is, how do you control the lighting and stability of the image? Because I mean, some of the patients are obviously elderly patients, and it's kind of difficult for them to keep
Yeah.
the leg steady. Yeah.
Yeah, so I guess the question has to be, is a bad image or a bad data input better than no input? And if yes, then you build that into the algorithm. But if no, then you don't accept it as an image, right? So you can build in the tolerances from the lighting. Um, you can also make adjustments. You can request or advise the patient to turn the brightness all the way. Okay. And if the brightness is all the way, you sometimes get enough just from that. But there's different things you can do to try and just increase the percentage of patients that will respond. You'll never get 100%, right? But if I got 50%, that's better than what it is now. And as we grow and incrementally innovate, right, each iteration is going to induce more patients to get it correctly, right? But remember, that's only one of the modes of input, right? We still will see they're walking. If they're wearing an Apple Watch, we've even had discussions with governments to provide the Apple Watch so that you can get the vitals from there, right? And then you overlay that, right? Because all you're trying to do is make it seamless for the patient. You can have the best ideas, but if the patient doesn't use it, it's useless.
Exactly. Exactly my point. Yeah, this is the point that I'm trying to elevate in people's mind. That number one issue is adherence, compliance. That's the number one issue. I also, I mean, you are with FDA, so you know the regulations very well. So I trust that, of course, you did the reasonable human factor studies, and the results were acceptable for you and for
Yes,
FDA at this point.
we did this out of Harvard at Farrell, so we have the peer-reviewed literature for that. But more importantly, we got through the Apple and the Google Health. That's almost harder than almost HIPAA and the FDA. So getting through the Google Health and Apple Health and the security of the data, that was very important.
I'm just wondering,
Thank you.
can I download the app and like can we try it?
Yes, hold on a second. Very good question. I should have put this in the thing because why not? Um, I put my email is jeremy@nstepcare.com.
Uh-huh.
Deb, if you could put it in the chat for everybody. Document.
I will do that right now.
Um, Let me see really quick. You know what? Let me drive. I'm going to do this. I will show you my actual physician dashboard. Okay.
Okay.
Because what I can show you is how quickly I can make protocols. And this is the key to everything is it's fully customizable to the provider. All right. So you guys can see this, right?
Yeah.
All right. Is go. And there you go. And here we go. Okay. So once you make a dashboard, you just click this button and you guys can see this, yeah? So that's my QR code. So if you're the patient, you go into my clinic, you scan this. So you can scan that.
Okay, give me a moment.
Yes, of course. And every provider or whatever, clinic, whatever you want it to be, gets a individualized QR code. So that's where the integration and execution part of all this lies, is it very quickly can get through or implement it into your clinic seamlessly.
So if I want to use this, should I email you and get a code?
No,
Is
it's the
that?
same thing. Scan
Oh, okay.
that.
Oh,
Yep,
okay. Okay, then give me one more moment. Yeah.
exactly.
Okay. Okay, okay. That's perfect. Collins, do you want to ask your questions?
Yeah, I was just trying to respond, but I can answer Collins if he wants to ask it for
Yeah,
everybody.
I was first of all, thank you for the nice presentation. It was very informative. I wanted to find out if your large language models were trained from scratch or they were fine-tuned or they were based on a RAG retrieval augmented generation application.
Uh, the first and the last, but actually all three, right? So we use multiple modes, but the different phases. So for the RAG application is kind of the computer vision, but we use our own LLM to basically trigger when to elevate severity or signals to the provider and the patient, right? We're continuously evolving that part. I hope that answers the question.
Yeah, okay, sounds good. Thank you so much.
Yeah, I'm not the tech guy. I'm just going to be completely honest. Like, I have a tech guy, and he can give you a 30-minute presentation on just your question.
Yeah, that would be interesting.
Yeah, yeah. But please reach out. If you do, we can always set up a meeting.
Sure, I will. I will put down your support email and see if I could get in touch with the tech guy.
Yeah, there you go. Or I put my private email or my direct email in there, and
Okay,
we can just send a scheduling link out.
thank you so much.
I'm just thinking of a use case for this in assisted living. If you
Yes.
have, for example, a nurse going to every room, so they
Hmm.
take care of the imaging and making sure that it's consistent between days.
Yes, yes. And then watch this. So I can make any treatment protocol that I want, right? So if you have like a Achilles tendonitis and I want to adjust um, what exercises I do, right? Like what exercises the patients have, I can do at-home physical therapy, and we have an entire library all the way for all the different specialties for musculoskeletal. But then other, we can also put like wound care instructions in there. And we're working with the different companies for them to basically give us the instruction videos or handouts to ensure that the patients are using the grafts or the dressings correctly, that sort of thing. But everything is customizable, the duration and the amount, right? So you can just change everything.
Very cool.
Thank you.
I downloaded the app. I'll play with it, have your email, and this was great. Very practical solution.
Yes,
Anyone
yes.
else? Any other questions? Okay.
Comments? No, nothing. Nobody want to tell us it's bad? Come on.
I will make sure that Bijan and David will watch this later. This is something that is down their alley for the most part. But as
Yeah.
I said, we will be through our page. We're supposed to be in assisted living facilities. So that could
Okay.
have been something we could think of adding to the protocol if we knew you then. But we'll see how it goes. There are some questions on how we will proceed with that
Uh,
project, but I have your email and then we will see.
Okay.
I have one quick follow-up question. You mentioned stroke. Maybe this is not for the whole audience, but I'm curious. Can you say a couple of words? What do you want to do with stroke, or what are you doing with stroke?
Yeah, so we're basically using the skeletal tracking for any of like the hemiparesis for the extremities, but we also our CTO and our design, our basically our tech team, their specialty is actually in the face. So any of the asymmetry in the face for those stroke diagnoses, or even the neurodegenerative diseases to just monitor recovery or, current baseline through the face. The motion in the face is where our expertise is. So that's what we're doing
Good,
for stroke and over right now.
good. All right. Thank you. But for the diagnostic purposes, if you have an acute situation, you do not have a baseline, so it's a little bit
We
difficult
don't,
to
we
yeah.
will not diagnose.
Right, right, right.
Yeah. No
Got it, got it,
diagnosis. Yeah.
got it, got it, got it.
Yeah.
Thank you.
Thank you. But definitely signals, right? So if those signals arise, right, which is like stall deterioration or any of the stroke signals, we let people know. That's simply all it is.
Yeah, thank
Yeah.
you. Got it.
I will mention, one of the things we're debating is how and if we should crowdsource the family in the stroke patient. Because, in the United States, if you have a stroke on a Friday, your outcomes kind of vary. If you have a stroke on a Monday or Tuesday, because the ancillary staff or the therapy staff, it's basically down, man, there's not as many people there on the weekend. So, you're kind of at the behest of when you get sick or injured with stroke, which is kind of what we're focusing in on, is the time sensitive nature of it.
Yeah, we do have one asset that is targeting the earlier minutes or hours. The problem is exactly as you said. The problem is how quickly you can get to the patient and how quickly you can actually get the diagnosis, because there are different types of strokes, and unfortunately, our asset works in opposite directions. So
Mhm.
you should do the correct diagnosis, just not to hurt the patient. And
Right.
then it can be very helpful. But again, it should be all happening in the first hour, if not less. And
Yes.
we have a problem with because there is no really yet the diagnostic condition in the in the car.
Yeah.
So that's a challenge.
Well, I'm glad you're working on it because it seems like there's a unmet need.
Ah,
So hopefully we work on unmet needs.
Yes,
Yeah,
yes, yes.
hopefully.
ah.
I
All
wish you
right.
well. And let me know if I can help in any ways.
Okay, definitely. We'll follow up.
Thank you. Okay. Priya, we're
Okay.
good?
Thank you very much. Appreciate your time, and let's keep in touch.
Yes, sir. Thank you very much. And I will share the deck with you to give to anybody interested.
Appreciate it. Thank you very much.
Thank you.
Thank
Bye-bye.
Bye-bye.
you. Bye.
Thank you. Bye-bye.